Megan, Albert and Megan, go ahead.
All right. Thank you, everyone. That was a great opening talk, but I'm happy to also introduce Megan Huisingh-Scheetz. Dr. Huisingh-Scheetz is a geriatrician and clinical investigator, assistant professor of medicine here at the University of Chicago. Megan studies the role of activity in the pathophysiology of frailty and aging. She analyzes accelerometry data to assess and trend activity patterns as markers of frailty and to inform frailty activity interventions using the National Social Life, Health, and Aging Project dataset, the National Health and Nutrition Examination Survey datasets, and local datasets as well. In partnership with NORC and Orbita Incorporated, Dr. Huisingh-Scheetz has also developed and is studying the impact of an intervention called Engage, a technology-based tool utilizing a voice assistant to deliver exercise programming to older adults in their home to reduce frailty. The program leverages caregivers to provide social motivation to the older adult to simultaneously combat loneliness. So this is going to be a great talk, and please enter questions that come up in the chat box. Dr. Huisingh-Scheetz.
Thank you, Dr. Huang. I really appreciate this opportunity to talk this morning and tell you about this experience we've had trying to build technology for all of the people that Dr. Shaw just said wouldn't use technology. So this is a work in progress, and it's been a learning path, certainly for our team. And I use these opportunities to get more feedback from other people about next steps as we sort of tread cautiously through this project. So again, my name is Megan Huisingh. I'm a geriatrician in the section of geriatrics and palliative medicine. And just going to talk to you today about one aspect of our tech work. And this is sort of our project developing Engage, which is a program that uses Alexa to support frail older adult activity in the home, and using or leveraging care partner relationships to socially motivate and socially engage older adults as they become more isolated. I want to mention that while this work has largely been grant funded, including my K-23 and a few pilot awards, as well as some funding from NORC, Engage was a custom program build. So there is some intellectual property associated with it that's jointly held between the University of Chicago and NORC at the University of Chicago. It is not commercially available. We have made no money. In fact, I think I've actually probably lost money on this, but I did want to alert you to that. So today I'm going to talk just a little bit about our clinical motivation for this project. I'll give you some background on what frailty is and why it's meaningful to me as a geriatrician. And then we'll talk about what the Engage program is and how it addresses frailty. We're going to talk a little bit about why we're even using technology in older adults. And then I'm going to go into some detail about a feasibility trial that we did, and then kind of looking ahead to the next steps. And that will sort of provide some opportunities for people to give some feedback. So for that. So a little about our motivation. So this is a man we'll call Mr. Frail. He's a pretty classic patient of mine. He has lots of chronic illness and has been getting functionally and cognitively impaired over the last few years. It's sort of been a slow decline, but we're seeing now that he really can't get out of his house without help. And this means that he's also socially isolated. He can't see his friends anymore. And he's totally dependent on his wife, who is his primary care partner or caregiver, to do anything health related, to do anything social. So when I met him and saw his frailty declining, one of the things that I ordered was a 10-week course of home health physical therapy. It was great. He did a lot better. He started to become more active, spent less time in front of the TV. And then our Medicare reimbursed home health service ended, and he quit exercising, and he quit going out to lunch with his friends. And this is not an uncommon situation, where we get a little better with some activity intervention, but then they resume this functional and social downward spiral. I just want to emphasize a point here, which is that he is totally reliant on his wife for any of the health promotion interventions I might advise or recommend for him. So they effectively act as one unit. Frailty was a term historically used to describe someone who was weak and liable to decay or casualty and not durable. These are the definitions straight from Webster's dictionary. It's a terrible term. We now know in the last several decades of research that frailty is a medical syndrome that has multiple causes and contributors and lends someone susceptible to poor outcomes, including morbidity and mortality, especially when they're faced with a stressor. There are a lot of underlying molecular and genetic changes that occur with aging that lend an individual vulnerable to these poor outcomes, including mitochondrial dysfunction, cellular senescence, stem cell exhaustion, et cetera. And as these molecular and genetic changes accumulate, they then disturb physiologic systems. And several key system drivers underlying the frailty syndrome include changes to the stress response system, inflammation, and energy metabolism. Eventually, these physiologic changes manifest in the clinic, and we can detect them using some clinical markers that you see there. And we now have several decades of literature showing that these clinical markers are predictive of poor outcomes in older adults. And so in the absence of being able to directly measure the biology, which I think is where we're going, we are using these clinical tools to pick up underlying biological impairments. And this detection of frailty is very important to us in geriatrics. So because of the kind of growing evidence base of the value of using frailty markers as risk predictors, as assistance to help us identify specific impairments that are addressable, and to help us frame overall care planning, we started a frailty assessment clinic in 2011 called the Successful Aging and Frailty Evaluation Clinic. It's an outpatient consultation model in which we implement a formal frailty assessment within a comprehensive geriatric assessment. And our patient was filtered through this clinic. When you look at frailty measurement over longer intervals, like 5-year intervals, it is a chronic and progressive syndrome, much like other chronic illnesses and other geriatric syndromes, and the rate declines, people decline faster the older that they get. But in the short term, there are a lot of frailty state transitions. While the kind of overall movement is to a state of worse frailty, there is some reversibility. This is some unpublished data from our early SAFE clinic participants who were followed for a year. We've now seen a lot of frailty intervention trials emerging in the literature, and by far the interventions that have had the most success improving frailty markers are, of course, resistance and strength and aerobic exercise interventions. Protein supplementation likely helps, but when it's paired with an exercise program only. You need the sort of building blocks for muscle in order to make the protein supplementation actually valuable. You have to trigger the muscles to build muscle. There's been quite a few pharmacotherapies now studied to date, and some of them have had some positive effects on targets like sarcopenia, and others haven't shown any effects. The problem is they have a lot of side effects that have not made them really feasible in our vulnerable group. But more work is to come on that, and we certainly have a lot of room to grow, understanding whether these interventions change just frailty markers or do they actually impact our outcomes. But I will at least mention that it's really hard to go wrong with physical activity in older adults. It's been qualified as the ideal intervention for older adults by one of the frailty research grandmothers, Dr. Linda Fried. I don't think she'd be offended if I referred to her as a grandmother, even though she's not. There are health benefits across physiologic systems, obviously, but relevant to our patient, activity is really central to improving his functional and cognitive well-being. And the best part is that it doesn't really take a lot of activity to see some positive health effects. We all struggle to stay physically active, myself included, but older adults have some unique challenges. Many of them face cardiovascular, metabolic, and musculoskeletal system disturbances that make it challenging for them to participate. Another really important hurdle is, like the patient I presented, 1 in 5 community dwelling older adults require at least some assistance to leave their home. So we would consider them or classify them as homebound. And this is much more prevalent among minority older adults, multi-morbid older adults, and low-income older adults. So even if we had some community resources for sustaining activity, they just can't access them. They cannot get to them. Another major challenge is they rely on informal caregivers to support their interventions, not just getting out of the home, but even in the home. Not everyone has an informal caregiver, and those who have an informal caregiver, the caregivers don't have any training. And a lot of these interventions that we offer our patients are targeting the older adult alone, but really they have to be targeted at the dyad because they function together. Another major limitation for our older adults is really there are no Medicare covered long-term care exercise programs for older adults in the home. Most of our physical activity trials that we have for even frailty were done in person with coaches or other professionals leading those classes, which really minimizes the feasibility of getting our most vulnerable people into these studies or into these programs. And finally, I just want to emphasize this likely two-way street between social engagement and physical engagement that really worsen each other. People who are physically inactive are also socially disengaged and vice versa, and they make the situation worse for the other one. And so this is really challenging for our older adults, and also suggests that possibly using social relationships or social motivation, which is so important for older adults at this stage of their life, might help us maintain habits, healthy habits and healthy aging habits. So we developed a custom Alexa skill called Engage with our partner NORC and our industry programming partner. And this Alexa skill delivers exercise content to older adults in the home. Over my Alexa device is going off right now. Over the Alexa device, and it leverages the paired care partner to help send motivation and maintain social engagement. Our program currently runs on a HIPAA compliant platform that our industry partner sponsors. And this platform also pairs a website and a mobile application to the Alexa device. I'm going to talk about each of these user roles in just a moment. I think there are very few tech-based older adult content on the commercial market now, currently, targeting this user group. But on top of that, almost none of them, I can say confidently, none of them have ever been tested in a research setting for their value. So we really wanted to be thoughtful about that deficit while developing this content. So the older adults primarily interface with the Alexa device. They can activate the Engage program on their device by saying, Alexa, start new Engage exercise. Alexa then reads them any new encouraging messages that their care partner might have sent to them through this program. So for example, Mom, saw you did some exercises yesterday, great job. The program then walks the older adult through a daily exercise routine with instructions, pictures, and timed music. Every routine that is administered works different major muscle groups, and the routines alternate every day. So by the end of the week, they've hit all the major muscle groups, and we're also avoiding overuse by alternating the program. What's kind of a unique feature of Engage is that at the end of each exercise, the older adult is asked to rate how difficult the exercise was. And if it's too easy, the number of requested repetitions will increase in subsequent routines, and vice versa if the exercise activity is rated too difficult. So there is a mechanism for using AI to auto adjust the intensity and promote growth down the road. The care partners, who really could be children or paid staff or just friends, primarily interface with the website and mobile application portals. They can log into their account and they will see the schedule of activities for the older adult for that day. The calendar will keep track of when the exercises were completed because it's communicating with the Alexa device. The care partners also receive an email summary that reports how many exercises were done, but importantly, how many were rated too difficult as a safety precaution. So the care partner is keeping a passive monitor on the older adult to ensure that they aren't injured and or avoid injury. The care partners receive prompts to send encouraging messages through the website or mobile app, which acts a little like an email. They compose a message and push send, and it is read out loud to the older adults on their Alexa device. All of the data, user level data, that is the frequency that they're sending messages or checking their account or logging in, are kept on the HIPAA compliant server. So it allows us to assess how frequently people are using the program, and also how they're using the program and when they get stuck. So I want to just pause after introducing the Alexa program and kind of ask, why are we even doing this? Why use technology to target the least likely people to use technology? This is a real question, and one that we have struggled with from the very beginning. There's a lot of reasons that Sachin outlined in much more detail why we shouldn't be using technology for this group. Tech use gets worse with advancing age. It's worse among the people with the lowest amount of education, and it's the lowest among the lowest income groups. So we're really kind of setting ourselves up for an uphill battle, if you will, just selecting this mechanism. The reality is that we just simply will not have enough manpower to provide one-to-one support for frail older adults using health professionals or skilled services. And so out of necessity, we are exploring innovative ways to support them at home by using technology. But this is not this was not a pathway we chose lightly. So what are the factors that we need to consider aligning in order for this to work? Everything has to fit and work well for this intervention to be successful. So, as Sachin alluded to earlier, the internet access, the quality of the internet access, the device access, and all of the trimmings like the cords and the backup devices and all of the other tools that are essential to make these devices work all have to be equitable and easy to reach. We have to have mechanisms for helping with the tech setup. These older adults have to feel like the equipment they're using is private, protects their privacy or respects their privacy. They have to feel like they trust the device itself. Many don't. And then even if we're lucky to get sort of the device in their home and the program in their home, the program has to be usable. It has to be easy for them to open and walk through. It has to be adoptable, meaning they really want to use it. There's something meaningful about the content for that user. It needs to be adaptable, meaning it needs to adapt to a lot of different user impairments, and we need to make sure that it's tailored to different levels of literacy and also physical impairment. And then finally, they need to have some motivation to sustain use, which is a huge challenge for any behavior change program long-term. So there's a lot of issues here that we went into this program thinking about. We couldn't address all of them at the same time immediately, but our goal is to chip away at all of these so that when we do test this in the larger community setting, we will have addressed all of these at some level. So I want to just talk about a couple of key decision points we faced when we decided to go down this road and how we were thinking about using a tech device, things that we decided to do in order to facilitate this intervention's success. So the first big hurdle or decision we made was actually selecting the device. We did not think about a voice assistant at first. We thought about a web app and learned through kind of a participatory design process I'll tell you more about later, to consider a voice assistant. Why did we choose this? Well, the voice assistants are tech that uses the spoken voice as the primary input method, for example, as opposed to typing. They are smart because they employ artificial intelligence to interpret that spoken voice and act on that interpretation. The smart devices are really thought to help reduce the technology burden use for older adults because they're using a skill they already know how to use. They can talk, they know how to talk, they don't know how to type. And so many of them find engaging with the voice assistants easier. We also looked at these devices and found one or a few that have very large screens on them, which facilitates both an audio and visual communication component. And that really was helpful for our target user group. There are some programs, none that we are using yet, but certainly we are exploring, where these devices can be controlled centrally. So the user doesn't actually have to control them, but someone else who knows about tech can help do the setup and select the content and makes it a little hands-free for the older user. And then finally, several of these programs are piloting HIPAA compliant options since privacy is a major concern. And so since they are coming out soon, we thought that a smart voice device might be the best starting point for us. Just a quick look at the distribution of smart voice or voice assistants. they are not as prevalent as smartphones right now because they're sort of newer to the commercial market, but they are really rapidly being disseminated across the globe. So you can see, so the rise in, millions of devices that were shipped worldwide between 2015, 2017, just in 2 years, and a 40% increase in smart speaker ownership just in a year in US adults. So it's certainly becoming much more available and a much more feasible tool for us to use. There was a really interesting study that was published in 2020 by some colleagues at Northwestern that looked at user comments on Amazon to understand how and why older adults are using voice assistants. And the top 5 reasons they're seeking these voice assistants are for entertainment, companionship, home control, reminders, and emergency communication. And this was helpful for us because we see like a natural tendency for people to use these devices for entertainment, companionship, and reminders, all things that we're hoping to weave into our program. One major turning point for us was to really target this user dyad as a single user unit. This data from Pew Research Center suggests that most older adults rely on at least another person to help with the setup or to show them how to use a new device, a tech device, if they do get it. This isn't a group that is going to be largely operating on their own. They really are going to need someone else there. So why not create or design the program to target those people together? This is more Pew data, which looks at different ways that people over the age of 60 are using their time. And you can see that with an increase in age, there's actually an increase in leisure time. And older adults are spending generally more than 4 hours of their day in front of a screen. And I see this or hear this reflected in a lot of our patients, especially our frail patients who are really watching TV most of the day or a lot of the awake day. And so, one thought here is how can we leverage these sort of existing routines, these existing screen time for more effective activities in the home? I think people enjoy television to some level, but there's also, I think sometimes they do it because there's nothing else to do. And so it could fit into their normal routine by using the screen time to promote healthy aging behavior. Another lesson I guess we learned through this process is anticipating a really, really wide range of technology comfort in this group. While data I showed you and also data that Dr. Shah showed you suggests that older adults are just, notoriously the ones that aren't using technology, there's quite a few that are. And this data suggests that, there's at least a quarter of 65 plus adults who feel very, very confident using, internet. And in some cases, they're more confident than some people under the age of 18. Yet we also have this range, the largest proportion who don't feel confident using it. So we really have this broadly heterogeneous group of tech users, and we have to figure out how to program for all of them. Another example of this variability is from some unpublished data from my colleague, Dr. Boot at Florida State, in which he administered a mobile device proficiency questionnaire in different age groups. And you could just see, in the youngest group, the mobile device proficiency is quite high. Their score is very high on this proficiency questionnaire. And then the older adults that they tested just covered the spectrum of technology proficiency. So again, emphasizing that this is a really important an important group to anticipate. When we created Engage, we used what's called participatory design. This means that we integrated end users in the development process from the very beginning, from the time that we had a concept all the way until we built the first experience, full experience, to co-create. And this meant that we could adapt the technology to them and not expect the older adult to adapt to the new technology. And this was really our user groups here. The people we targeted in the co-creation were minority older adults who were vulnerable and frail and multimorbid. So we really tried to use their input along the way. I'll just mention, this is a timely process. We developed our concept about 6 years ago, and we took this to over 40 stakeholders in interviews that ranged from these homebound older adults to, CEOs of hospital systems and home health care agencies, and used that input to shape our wireframes, which were static, flat images of potential functions and potential screenshots of the program. We went back to older adults and care partners and user groups. Again, these were 100% minority older adults and caregivers, got their input, and then designed our first in-lab experience, and then went back to these focus groups again to get input, and then designed our first in-home experience. And I want to talk to you a little bit about our usability trial experience in preparation for our in-home trial. So the goals for our feasibility study were to first test our protocol feasibility, and then we wanted to assess the utilization over 10 weeks, collect some perceived benefits and areas for improvement through some qualitative interviewing, and then to estimate potential impact on physical function. We recruited 10 dyads from an independent living wing of a transitional care building. We specifically focused on this building because they were already testing Alexa devices in their units. So it allowed us to focus on collecting the experience information about the Engage program and not on difficulty using Alexa, at least for this first phase. Our timeline was over 14 weeks. And I bring this up because I think there's a couple key steps here. We did a lot of the recruitment and consenting and baseline collection the first 2 weeks. And then we did on-site setup for all of these older adults, even though they were they had Alexa devices in their home. And then we had a 2-week run-in phase that allowed us to fix any undetected program glitches. As many times as we practiced the program before going into the field, we still had glitches we didn't find prior to that test. So that was a really critical phase. The 10-week intervention phase was supported by weekly to twice every 2-week check-in calls and a free 1-800 hotline that they could call to get tech support from a human being. And then we did some follow-up data collection and focus groups at the end. The intervention for the older adult was to do the Engage exercise program ad lib. We wanted them to use it every day, but understood that their lives wouldn't necessarily allow that. So we just asked them to complete the program ad lib. The care partners were asked to check the online profiles of their older adults, keep an eye on their completion, to review the daily summary emails, especially the number of exercises that were rated too difficult, and to send encouraging messages as they would. We didn't guide them in that way at all. We just asked them to send encouraging messages through the platform. So just a quick look at this patient sample. They were actually pretty representative of age, older age. but they were largely college educated and tech savvy tech users. And they were almost all had some degree of baseline exercise. So not really our eventual target user group, but as I mentioned, it was a great one to test the actual content of the Engage and the usability. One really important finding was the self-selected caregivers, that is the older adults picked out their care partner, really represented a broad range of relationship types, much broader than we anticipated. Many selected friends or staff. One even selected their own spouse who lived in the unit with them. And then we had just a few that were children. Our implementation experience was that the pre-programming of the devices, the in-home setup, this 2-week run-in phase and in-home assessments were all crucial to the success of this trial. These are really difficult to ramp up in a large scale. So I do think it's worth knowing that, you know, there's some cost and manpower needs to making these tech programs work well in these high-risk users, but they're really essential to making it work well. Our sample were really high utilizers. They completed a full 25 to 35 minute routine 6 days a week on average. But I want to just mention that there again is some wide variation in users here. We had a couple super users. This is the frequency that each of these exercises were done over the 10 weeks. And then we had a couple that were, you know, totally self-admitted that they really didn't do the program more than a couple times over 10 weeks. So good to kind of keep that in mind for future studies. The qualitative feedback was helpful in this group. We got some real life experience from our participants telling us about how their strength gains impacted their life activities. This one was a really funny story in which the person was able to open a pickle jar more easily, and the grip strength exercise actually tells the user that they will be able to open pickle jars more easily. So it was a really funny full circle there. We had some people reporting that they actually gained knowledge on how comprehensive the exercise programs need to be for people in their age group. And again, these were people who were baseline exercisers. So I think a good take home was just that everyone can benefit from a little extra support and teaching. Another important recognized valuable component was the social component. We actually had one participant say it was the quote best part of the entire program. So a lot of support for using that social relationship. We had a number of program edits that they suggested to make the experience a little bit more enjoyable, making the routines a little bit more variable, streamlining the instructions. Some wanted more control over some of the exercise adjustments. People who were very, very tech savvy wanted that. And then what was really interesting and what I want to highlight is that some felt like their care partners didn't meet their expectations. They were hoping their care partners would have gotten into it a little bit more to support them, and really showed us an opportunity to help provide information to the care partners about how to be good motivators. So just a quick look at our potential estimated impact over 10 weeks. Of course, we weren't powered for efficacy in this pilot, but we did see surprisingly a significant improvement in chair stand time and a trend towards improvement in grip strength. And then we also analyzed this using kind of a minimally clinically important difference, which I'll skip over due to time. And then we're looking ahead now, and we're fortunate to be part of Dr. Huang and Lynch's Chronic Disease Center that was just funded, and we will be testing the efficacy of this program in our target users, community dwelling, African-American, multimorbid, older adults and their care partners. I think outside of just our first aim, which is to test the efficacy of this program, perhaps even more important is we have an entire aim dedicated to identifying moderators of Engage use and efficacy. And they span from individual to community level moderators. So we're measuring technology literacy. We're measuring baseline cognition, number of chronic illnesses. We're measuring the frequency and quality of their care partner relationships. And we're measuring household internet connectivity quality, number of times it's disrupted, and we're able to adjust for these throughout the trial. A few take-home messages for the group. One is that tech can be adapted to older adults. It requires a really dedicated process and one that we're still learning but are working on. These logistics for these trials and also the success of these programs, logistics are really crucial. And we have a few more we're going to be testing, but I think we've learned a lot so far that can guide other tech-based programs in these high-risk groups. I think we have room to improve our supportive care partners as the yin and yang component of the older adult and care partner dyad. So we'll be working on that in our upcoming trial. And ultimately, we'd like to expand, the features and contents and really offer some evidence-based programming for our patients. I gave an example here of Mayo Clinic doing that so far, right now. So just thanks to this team, it was a big effort. Louise Hockley has been my co-partner in crime for a long time, and happy to take questions at the noon hour if we don't have time now.
Thank you, Megan. That was a inspiring talk sort of about the future of virtual healthcare. And we have unfortunately run over time. So we're going to save questions for the extended Q&A session at noon. Mary, can we end this recording?
Certainly.